All right, concerning mechanisms. So a fall of 3 feet or greater for an adult from standing, and anybody who falls down 5 or more stairs, that falls into that adult range. Motor vehicle crash at 30 mile per hour or over, rollover ejections, motorcycle, bicycle, or other mobile transport device. So that means something like a moped, or it could be a motorized wheelchair as well, or a pedestrian struck by a vehicle. Diving or axial loading, and electrical shock as well. Symptoms of spinal cord injury, spinal column injury, posterior neck or back pain or tenderness, paresthesia or loss of sensation in extremities. So paresthesia is the sensation of numbness or tingling, often described as like a pins and needles sensation. Anybody who has ever had an extremity, quote unquote, fall asleep, that's one of the descriptions of the sensation, paresthesia. Weakness or paralysis of extremities. Any condition that's going to place an individual at risk to not perceive or complain of the symptoms of spinal cord injury. So things like altered mental status could be from a disease process such as sepsis or tox. It could be from head injury, intoxication such as alcohol, or other causes. Anything that's really going to inabilitate them to adequately communicate. We really have to be careful with the intoxicated patients. Because this, if not properly assessed and managed, these patients can definitely open up a legal nightmare for any healthcare provider. It's easy to just kind of pawn it off and ignore some of the either complaints or the non-complaints of somebody who's intoxicated because of the state that they're in. They may not be able to properly tell you what hurts or of any numbness or tingling sensations they may have due to the alcohol blunting those responses. So any history of cervical spine injury or abnormality, conditions causing fragile bones such as osteoporosis, distracting injuries such as a long bone fracture, or age extreme. So anybody over 65 years of age automatically gets a collar. Sounds like a lot right now, but in a few slides we'll pull up the flow chart, which really simplifies things and gives you a really good understanding of what we're looking for to rule in or rule out a cervical collar. So individuals that sustain lesser injuries, patients who do not have symptoms of spinal column injury and do not experience a condition that would impair the patient's ability to perceive or communicate symptoms of spinal column injuries, do not require spinal mobilization. So that means that anybody who falls into this category and does not have any of these conditions, such as altered mental status, history of cervical spine injury or abnormalities, distracting injuries, things of that nature, won't require a C-collar. So as long as we document this appropriately, we assess this appropriately, we're actually going to be providing better, more comfortable care for our patients. Would like to add that penetrating injuries to the neck generally do not require spinal immobilization. With that being said, if a bullet wound is found and the pathway appears like it could, or a stab wound, the pathway appears like it could penetrate into the actual spinal column, chances are you're going to have some significant symptoms and findings on your assessment when that happens. But generally, these patients don't require spinal immobilization. All right, so here is protocol 6.3. You can see it kind of works through EMT, advanced, paramedic standing orders as protocols generally do. If this is difficult for you to see, I would recommend pulling up the protocols or pulling out your protocol book and kind of reading along as we walk through this. So we want to ensure safety of the scene, appropriate universal precautions. So that's your BSI, request additional EMS or resources as needed, whether it's ALS, BLS, or maybe the fire department for extra hands. Perform your very thorough primary survey. Treat any life threats that need immediate attention and appropriate oxygen and IV therapy for these patients. So, standing orders, general protocol. All right. Let's kind of skip through this section here and move down. So, if patient is assessed as stable and there's suspicion of possible C-spine injury, begin assessment and history to determine if the patient needs to be placed in a collar and undergo spinal motion restriction. Mechanism of injury should be used as a historical component of the assessment and lead to further spine assessment. So axial loading caused by diving, blunt trauma, motor vehicle crash, falls greater than 3 feet, an adult falling from a standing height. Motor vehicle crash applies to crashes of all motorized vehicles, again, automobile, motorcycle, snowmobile, etc. Then we're going to follow a spinal immobilization process. So, establish manual C-spine stabilization in the position the patient's found. Assess for correct size and properly apply cervical collar. Make sure you're checking your CSMs prior to applying the collar as well as after application of the collar. Move the patient from the position found to the location of the ambulance. Stretcher utilizing a device such as a scoop, longboard, or if necessary, by having a patient stand and pivot to the stretcher. Now, if you're going to have them stand and pivot to the stretcher, don't have them struggle, right? We still want to assist them. But some of the studies out there have shown, for example, a patient who is going to stand up and get out of a vehicle, by them doing so, as soon as they feel the sensation of pain, they're going to stop that motion that's causing the pain, and they're going to find a better way to do it. Us pulling people out of cars and manipulating and sliding them out on a board can actually cause more damage or cause new damage to occur. Next, position patient on ambulance stretcher. Remove scoop or log roll the patient off of the long spine board or other device. Remember that these boards are not comfortable. They are great for manipulating patients or moving patients if need be. But they're not really comfortable for the patient. So the sooner we can get them off of that device, as long as it's appropriate to, the better that's going to be for our overall patient care. A blanket roll or blocks and tape attached to the stretcher may be used to minimize lateral movement of head during transport. Once on the ambulance stretcher, instruct the patient to lie still. Should elevate the head of the stretcher to 20 to 30 degrees, position of comfort for the patient. Secure the cross straps and up over the shoulder belts firmly. Utilize a slide board at the destination to move the patient smoothly to the hospital stretcher. Ensure appropriate documentation of procedure in patient care report. So all of these 11 steps here should be properly documented in your patient care report. And that includes documenting utilizing a slide board at the destination to move the patient from one stretcher to the other. Now, jumping into the medical control portion of this selective spinal assessment. If it is determined through a complete assessment that the patient is reliable, has no distracting injuries, has no abnormal sensory or motor deficits, has no spine pain or tenderness, we don't need to immobilize. So let's move on to the next page of the protocol. Here we have the flow chart that's very simple and easy to use. So you can see we start off up here at the top. Mechanism, spinal assessment protocol. So mechanism of injury, axial load, blunt trauma, motor vehicle crash, bicycle, fall greater than 3 feet, adult falling from standing height. We start to follow these arrows. So age 65 or older. If the answer is yes, we automatically put a cervical collar on. Okay. 65 years or older automatically gets a C-collar. If the answer is no, we move on to, is the patient reliable? So are they alert and oriented times 4 with a GCS of 15? If the answer is yes, they are unreliable, we move on to immobilize. If the answer is no, they are AOC times 4 with a GCS of 15, then we can move on. Do they have a distracting injury? If the answer is yes, they have a distracting injury, we immobilize. If the answer is no, we move on to the next box. Do they have a abnormal sensory exam or motor exam? So when we check our CSMs, are we finding any weakness to any extremity? Are we finding any signs of paresthesia, numbness, tingling, any abnormal sensations to any of the extremities or body? If the answer is yes, we immobilize. If the answer is no, we move on to the spinal assessment. If we find no pain and no tenderness, we move on. But if we do, we immobilize. So if we've by this point we have checked all these other boxes off and we're still in this no category, we hit no one more time, we can follow this protocol and not immobilize this patient. So this is going to be good because there are quite a few of our patients who will actually fall into this don't immobilize category. Keep in mind that a majority of our patients who do fall, however, are the age of 65 or older. So already at this first box, we're going to be immobilizing the patient. We have taken this flowchart here and have put it onto a ID card. Prior to rolling out this protocol change, we are going to be distributing out these little cards that will have the flowchart on it for you to put right with your ID badge, so that at any point in time you can reference this chart to figure out whether or not you should immobilize a patient or not. We are also going to be putting a copy of this protocol right into the binder in the back of the truck for your reference as well. So it should be easily accessible. I just want to finish up by talking about these 4 boxes down here at the bottom. So let's review those. So the first box is abnormal sensory motor exam. If based on the assessment the patient has any abnormal neurologic findings, including but not limited to paresthesia or loss of sensation in extremities, weakness or paralysis of extremities, loss of urethral or sphincter control, so bladder control or bowel movement, then automatically immobilize. One underneath it is complaints of pain or examination tenderness. So complete an assessment of the patient's spine for pain or tenderness. The assessment should include, but it's not limited to, palpation of the entire spine, posterior, midline, and cervical. Range of motion, if it's appropriate. So that means that if they have tenderness or pain on your initial palpation, we do not do range of motion. If they have no tenderness, no pain, then we can do our range of motion exam. If based on the assessment the patient's experiencing any pain or tenderness along the spine, automatically immobilize. Our distracting injuries, it's any injury that's going to produce clinically apparent pain that might distract the patient from the pain of a spinal injury. Pain would include medical as well as traumatic etiologies of pain. If based on the assessment they have a distracting injury, you immobilize. In the last box, patient reliability. So is the patient intoxicated, have an altered mental status, is having an acute stress reaction at the extreme of age, or any other reason that results in the inability to either adequately perceive or communicate symptoms. If the patient is unreliable based on the assessment, immobilize your patient. And last but not least, if you have any further questions, please don't hesitate to come see me. Shoot me an email, shoot me a text, so that I can answer any of your questions. I want to make sure that you guys have a great understanding of this protocol, because it's a great protocol change that we're going to be able to implement for the comfort of our patients.